So I've changed this around. I'm going to talk about halo, and I'll talk about MIS and geriatric odontoid fractures, and we'll show 2 cases from last night that were not shown yet. Rapid fire. Timer on. Lee? Lee, do you have the timer?
1 second.
Okay. So, halo. Revisiting it one more time. Last night, for those who were there, you had a lively halo debate, and the only one who stood up for halo was Professor Schroeder. Everybody else poo-pooed it. I stayed neutral. Assume, ladies and gentlemen, this is you. And by the way, let's get some, can you guys get some audience response systems to our faculty? They should be able to vote. So we need 2 more. So assume this is your odontoid fracture or that of your loved one. It's a mildly displaced injury with gentle traction, 5 pounds. It snaps into place. When the patient gets up, this odontoid tips off backwards. There's an isolated injury. This is you or a loved one, healthy individual, okay? So I'm just going to quickly go for question number 1 here, if we can switch to the questions. After all you've heard, thank you, Alex, for your great help before. That doesn't count for the time, the switching time. Mackenzie prepared some questions. We need another ARS module for Dr. Daly. So this is you. Middle was with 5 pounds of traction, perfectly aligned. Then a collar was put on, and the neck slips off. So, number 1 question, do you accept halo treatment if you had a reasonable chance of healing a neck fracture? I've shown you in this case that you can get it perfectly aligned with small traction, nothing much there. This is you. Is a halo the reasonable option to treat this with? Just simple yes or no. And we'll look for the answer. And if it's more than 1, Josh wins. Whoa, that's a big shift from last night. More than parity. Josh?
I would say, I think we need to remember we have a Minerva, we have a SAMI brace, there's several other contracts. They don't need to put pins into our head that are very good at controlling.
This patient is a real patient, was put into a Miami J collar with a thoracic extension. This is a reasonably athletic person. This is a person in the 40s, mid-50s, as I remember. So that slipped off with that kind of a thoracic extension. It did not have a headband on it. I'm not sure what the compliance with that would be. Let's go question number 2. We need to be rapid fire. Sorry, Josh. What is the leading rational argument?
We can't see over there.
Oh, sorry, we have to, can we technically change that around? Great, thank you. Thanks for pointing that out. What is the leading argument against halo use? You can only put 1 or number 6 down. And
Say all of them.
you can only choose, I said leading for a reason, because there are a lot of thoughts. Cumbersome, great point. It's just clumsy, right, Ed? How many halos have you put on at Harborview in the last year? None. Now, let's switch back to the slide. Sorry, Lee, I keep you running there. So this is very interesting. Pain was another leading thing. The other factors were very marginal. So going forward rapidly, this is a Harborview paper. Do you remember that? Is that still taught, Dr. Young? Almost 300 patients, 7 years. This is a truly consecutive group, 40 odontoids. About 35% of patients did not heal. A quarter did not complete the intent to treat. Pin tract infections are very rare. These are some cases. An example, healed beautifully at the end. This is the fracture types. I'm going to fast forward to this. This is a nice distribution of real-life practice. And again, failures by age, frequently quoted. When I look at the 8th and the 9th decade right here, I do see a spike, but the spikes also occur in younger age groups. So if we put the age group somewhere at 75 or 90, you could say there's a problem with that, but that could also be patient morbidity. So this fact that failures are an age-specific thing did not hold up statistically. Failures by time. Now here was a surprise. Dr. Bransford found that the failures happened really early on in the first 2 weeks. And after that, pin tracts and basically other factors became an issue. So in fact, this is not highly statistically significantly related to age. Time 12 weeks is enough. Dr. Schroeder said that last night. But basically, we can probably predict failures very early on. And if those patients within the first 2 weeks are taken out and rendered to the surgery or definitive treatment, you actually have a very reasonable treatment option, right? I mean, so this is, if you basically take that first left blue line, you have a pretty reasonable treatment option. So what can we conclude? I ask our 4 experts to kind of discuss this very briefly, so like very brief 1-2 minute sentences. Does this change any of your opinions? Andrew, let's start with you. Dr.
Absolutely not. I don't think pin track infections.
Is your microphone on?
Can you hear me? Yeah. I don't think pin tract infections are completely benign. We took care of 2 patients, Jens, one when I was chief resident, one when I was your fellow. Both of them had temporal lobe abscesses from pin tracts that were imploded all the way in. One of them died. I'll never forget that. So I don't think that all halo pin tract infections are as benign as possible.
Okay.
The other problem is, remember, compliance was an issue. We'd often see patients come back in, their halo in their hands, all taken apart. People just weren't using it. So I don't think they're as benign as we think they are.
But compliance in general is pretty good if they show up to their follow-up appointments, which was every 2 weeks or every week at the beginning.
Exactly, if they show up. If they're not over in Bellingham or whatever, you know, screwing the pin tracks further into their temporal lobes.
Dan Gelb, do you agree, disagree? Did this change any of your pre-held conceptions?
I don't treat displaced ankle fractures and long leg casts anymore. We've evolved. It doesn't change my mind.
Okay. And Josh, do you feel confirmed in your opinions?
Looking at your statistics beforehand, it was interesting to see that there's a large proportion of patients that die in the first month and a half. If they would die after surgery, would that change everyone's perspective on operating on all of these patients with a 20% death rate?
Attribution is a very significant thing, no question. And again, severity of injury, aspiration, et cetera, is an issue. We did not find a correlation of aspiration and halos, by the way. These are all assessed by an independent team. Rick, any new thoughts on this? I mean, if a patient absolutely denies a declined surgery, is a halo still something you'd consider, or because it's so fallen out of use, you would just not even consider it?
Well, again, it depends on their age. If they're older than me, no. And even me, I would not put myself in a halo. I like what Dr. Gelb said. I would more rather have a collar and see how I did. And if it didn't heal and it was symptomatic, then I'd have an operation. If it healed, great. But, I think, the chance is going to heal super low.
When you have a patient a collar, Dr. Anderson taught us a very simple thing, which I really liked. He got an x-ray with the patient supine in the collar and then an upright lateral. And if it didn't displace, the patient was at least theoretically clear to go. Is that something that you'd recommend, or do you have tips and tricks in terms of how to run a collar program?
No, but I like that loading, physiologic loading, and see what happens under gravity. You need to get those x-rays as opposed to always having them supine.
All right. Any other thoughts from anybody? This is fair game. Any question is fair game. Otherwise, we'll have to conclude that the halo is a past tense thing outside of Israel. Dr. Van Grimsky.
Just as interesting because how do you do the aftercare for those patients? So is there a special clinic for halo patients at Haberview?
We used to have that, but I think several speakers have said that it's very labor intensive, actually. We had a nurse dedicated on that. Patients do pin track care with peroxide, no gunk. They can't change out their vest lining very readily. They have to come in for that, and we actually recommend against it because that, again, necessitates a number of repeat x-rays. The best predictor of halos working mechanically is torso fits. That's a frequently asked question. So the more tight the halo vest fits on the torso, the better. If you have a very large patient, you're on a lost cause right from the beginning. Eric.
I used to tell my patients it's an operation that's going to last 3 months.
That's a great line. I'm going to adopt that. Thank you.
Say, we don't put halos on elderly patients, but I think young patients have got kids in halos, multiple level fractures where you're going to do a lone construct. I had a child with an occipital-cervical dislocation in 4 vertebral bodies. And I think if you're sticking them in a halo and you stick them, they get it 3 months later, they get some motion. It's better
All right,
than doing occipital.
one more question, we need to move on.
It's probably
Oh, wait, didn't Eric want to talk? Oh, you're not going to let that. Okay.
We got, at my hospital, we use a lot of external fixation. We have a lot of patients with joint infection or a long bone infection, and we treat them like for 3 months in an external fixator, which is not comparable to a spinal fracture, but still those patients go along with that fixator and come to our fixation clinic, so it kind of works. And they have this operation for 3 months as well, if you want to say it, but it heals, so it's maybe.
Dr. Elizarov.
One question I had is related. I did very few halos during my residency, probably count on one hand. But one thing Arby always mentioned was loss of spinal muscle, musculature, especially in the elderly. He would always say they had a chicken neck or something afterwards.
Vulture neck.
Vulture neck. But is that a clinically real problem? Do these patients get out of a halo and have suddenly a dropped head deformity from inability
Let's
to split the
expand
neck?
that.
Or?
This is, I will editorialize, not resigned to halos. This is a immobilization or collar-related thing, as shown in our paper with Maximilian Reinhold. Muscle atrophy after external immobilization and cervical spine fractures or whatever in elderly patients. Problem or not? Josh, you answer first because you still put halos on patients.
I've never seen it as a problem.
So we've actually written it up. They fall forwards.
Yeah, absolutely. I mean, you have to wean them from one collar to the next. Oftentimes, they go from a halo to a hard collar to a soft.
But the bigger problem is stiffness, in my experience. Like, it's not weakness. It's they're all spondylotic, and then you put them in a collar for 3 months, and they'll never move their head again, or it'll be painful when they move. I think that's a good argument about fixation, to get them out of the collar as soon as you can, because whatever motion they have in the rest of their cervical spine, you want to maintain. And the longer you hold them up, the stiffer they get.
So just final thought for Rick, then we'll definitely move on. These are, by the way, both patients of mine. They both did very well, and they both gave me permission to show these pictures. So I just want to make sure that everybody knows that this was done with full acknowledgement. The upper patient actually sent me her pictures with various activities. Rick, so this is what I've usually seen in non-operatively treated 3-month immobilization patients. Is this just something we did wrong? Did we not pull enough? Or when Dan talks about stiffness, I would challenge him to do a repeat alignment study and see how his foramen magnum to C1, C2 angulation has changed and how the T1 inflection angle has changed. So iatrogenic immobilization caused reversible through exercise?
So what is amazing to me is hearing advocates for non-operative treatment, halos, collars, whatever, saying motion's going to be normal. It is never normal after these injuries, whether we treat them non-operatively or operate on them. And actually, I think, as Dan said, we operate on them, we get them moving right away. I think they'll have better motion than what they will have after halo fixation.
Final follow-up question. Lee, I think we have a question on this, right, Mackenzie? Do you have a question on this? No? A final halo question?
Just the 2 halos.
We had just 2 halos. If there's no 3,
Just 2.
then we'll move on. Good. Thank you. Now we'll go to topic number 2, MIS and thoracolumbar spine trauma. So this is something I picked up on from all the speakers. I'm not an MIS surgeon. I trained in it. I've used it a couple of times, and for a variety of reasons, including radiation exposure, I felt it's not something I want to do. Very briefly, 26-year-old male, super healthy. He's a firefighter, smoke jumper from Arizona. Loading an ATV, the ATV rolled off the truck and folded him in half. Severe pain, neurologically intact. Briefly, can I put you on the spot, Rick? Injury description, this is a CT. How would you rate
Yeah,
this?
so he's got a B fracture.
Yeah.
So if you want to call it Ferguson-Allen flexion distraction injury, I think you could do this from the back. This is a perfect indication for what you just did.
Dan Gelb, MIS. This is a firefighter who doesn't want his muscles poked. He's heard you're so good with your percutaneous screws.
Yeah, I think you can certainly do this MIS. My indications for MIS generally are people with multiple trauma who won't tolerate an open surgery, or someone who has soft tissue envelope problems. So this guy got run over by his ATV and had a huge Morel level A, or a lot of abrasions on his back. So I thought that the skin wasn't appropriate. I would perk him. If it was an isolated injury and the soft tissue envelope was good, I would probably open it. I don't think it's a problem with fixation in the short term, and most young people heal. But long term, the screws get loose, and we have had to go back and take them out. But I don't think there's any deficit to immediate stabilization and mobilization, I think it's a long-term screw loosening issue.
I'm going to ask a pointing question to Andrew. Do you guys have a visionary kind of a joint force department, orthoneurosurgery? First of all, MIS, yes or no, is that an option? And secondly, and this is the more pointing question, are there differences nationally and locally in Utah and Salt Lake City between orthoneurosurgery and their penchant towards doing MIS?
Absolutely. I mean, I think it's, very popular in neurosurgery to do everything MIS. The question is, how do you get the fracture to heal? This fracture, I think, will heal because it's a B type of injury, and so the fracture will heal directly, so you don't have to open it up and put graft in there. So I think percutaneous, sort of MIS, if you will, technique for this is very reasonable. I think if, it's a big fracture dislocation and you have to put a bunch of graft in there and try to get the patient to heal together, that's a different story. I have a very difficult time doing that MIS.
So patient was neurologically normal, isolated injury despite the significant injury mechanism. Let's switch to the questions, please. And so is MIS the preferred treatment for this patient? You've heard our visiting professors, and whilst we're switching, Josh, MIS, yes or no? 2 robots or 1 robot?
I would say the most important thing here is the spinal alignment. I think that stabilization percutaneous is yesterday's news. This is easy enough to do percutaneous. The question is how much of a sagittal alignment you're going to get him. You seem to take a lateral X-ray once you place him on his stomach and see if it reduces. You can easily perk him and it will heal. If it'll stay kyphotic, then you may as well, you can do a long construct percutaneous, but you got to try to get a better alignment.
So the audience sided with you guys. 3/4 think that MIS would be the way to go. Let's switch to question number 2 here. So this is a T11 flexion distraction injury, also labeled as AO type B2 without spinal cord injury. Now, let's talk about levels. So I just showed you a short fixation, 1 above, 1 below the injury. In this setting, if you want to do MIS, since this is the recommendation of the majority, would you do 2 or 3 above or 2 or 3 below? So a long or short fixation? That's the question. So please vote. Number 1 is short fixation. Number 2 is long fixation. And the audience has voted, and we have parity, a slight preference for short fixation. Interesting, good. How do you comment on that, Rick? Is that a legitimate thing? There's some lever arm, there's some kyphosis. Do you have a better chance at correcting the kyphosis? We can switch back to the slides, please, Lee.
Again, I think that if you have significant anterior column stability, a short segment will work, but if you don't, you need to go to long segment fixation in the back.
What did you vote for,
Absolutely.
if you're willing to divulge that? Long or short?
Long.
Long.
Yeah.
Josh, concurrence?
If it reduces short, if it doesn't reduce long, again.
And both Andrew and Dan?
I'd wait to see when you got them on the table. If it reduces, I go short.
Agree.
Okay, so this is what was done. This is in Arizona. Now, critique this. Dan, you have the microphone. So they did a transfascial approach. You'll notice that the skin staples go from top to bottom, but the operative record states that they basically did through fascial pocals. I'm not quite sure why, but they said that they had wound healing problems when they did too many screw holes next to one another. So I'm just going to leave that at that. This is outside of our control. What are your thoughts as you see this long construct, 2 above, 2 below? The patient remained neurologically intact.
I'm not happy with that. I think they've failed to get either get the reduction by postural methods when they put them on the table or by working the rod. The rod's not contoured correctly. It's contoured in kyphosis. And I think that's doomed to failure. I think, as I said, even with a percutaneous fixation, you can use a cantilever type correction technique and make this better. I would not be satisfied. I would not be especially happy with this, especially on a long segment, because now you've put him, even a longer segment of his spine is stiff and poorly positioned.
Andrew, a certain colleague with the initials of DB has done this case, and you're on call, and he's out lecturing somewhere. Would you take this patient back, or would you do wait and see and put him in a brace?
It depends on how he was feeling. I mean, if he said he could mobilize and was doing relatively well, I would probably kind of follow him along. I don't think I would, just for political reasons, I wouldn't go ahead and usurp someone else's authority. I think that looks bad to the patient. I'm sorry. I think we have to be cognizant of that.
Let's have the right wing, or is it the left wing? Depends on matter of perspective.
Well, I just want to be clear. I wouldn't be happy with this thing. That doesn't mean that if somebody else showed up in my office with this looking like this, that I would take it back to the operating room, because I wouldn't, right? I mean, I don't think this is so heinous that I wouldn't let it play itself out to see how the patient did. I'm just saying if I was doing the surgery and I saw that on my fluoro spot, I wouldn't leave it that way.
So Josh, this is a high impact guy. This is a professional firefighter. He's a smoke jumper, so he's like a paratrooper without a gun. Is this going to heal or is this going to fail? How's the patient going to do?
It's going to heal, but it's going to heal badly, unfortunately. I think the fractures heal. I think it's exactly the case that you showed yesterday. He's going to have thoracolumbar kyphosis. Either the screws are going to pull out, or when they come out, the guy's going to be miserable, unfortunately. And you need to take him back in a year or so and do a osteotomy, most likely to correct him.
Variation of the same question, Rick. How and when is it going to fail?
Again, I think it will heal, but it will be a sagittal alignment issue. He's kyphotic.
Okay. Postoperative CT, do you want to amend your view? This is what was done here. I call that an OIF, an open internal fixation. So there's no open reduction internal fixation. The R was skipped. Andrew, do you want to change your mind? This is going to heal in malunion or?
Again, I'm not sure it's going to malunite, but it's going to heal in malposition. And so I do worry about that. But again, if this guy came under my care, I might go ahead and redo it.
So this patient changed locations. He actually moved to Washington State. He couldn't walk. This is a totally tough guy. He's like a dream patient, super guy. He had significant back pain. And I actually put him into a brace when I saw him first because he came without a brace. Neurologically, he's intact. Now, do we have a question for this, Mackenzie? No? So just show of hands. Who would wait and see? Show of hands if you're willing to do that. Wait and see for 3 months. Show of hands. Raise your hands, please. Okay. Who would revise him now? Okay, so almost parity. So the patient comes back. We actually got a new CT. Everything remained the same. He was very uncomfortable in his brace, and he actually then said he wants surgery. He got tingling in his feet. We re-imaged him. There was 0 bone growth. Actually, I can take that forward to 6 months. There was no bone graft visible anywhere. They obviously relied on posterior element healing. Eventually, it started to heal a bit, but he remained very uncomfortable. When and how do you kind of accede to the patient? I really tried to be very honest with him. I told him exactly what you said. He'll heal probably, but it'll heal in a deformed position, and he became increasingly unhappy. So I'll start with Rick. Psycho-counseling, encourage him to hang on longer. We actually did 3 months of bracing, 3 months of PT. No hardware failure visible. Very unhappy with his gibbous. I'm not sure what these neurologic presentations are from. He had no long tract signs or anything else, no conus signs.
So you're 6 months?
6 months.
6 months.
0 healing. I got to repeat CT.
Yeah.
0 healing.
I
No
think
hardware
it's-
loosening.
I think I would give him the option of revising him.
Josh, this is an IDF member. Would you let this young soldier, if this is a soldier, go back to active duty with a CT that looks like this? 0 healing.
No, I don't think so.
Would you let him go back, or her, if this was healed and malunited?
In fact, I mean, regardless, if it's healed beautifully with such a long construct, I would worry about adjacent level pressures, and I would worry about sending him back to that combat unit. Had I taken out the hardware, let's say it healed nicely and I took out the hardware and it stayed normal, maybe yes, but it would need a long PT program before it go back to active.
Andrew and Dan, the left or right wing, however we want to view you, kind of concede defeat or try to do some cognitive behavioral therapy?
I'm willing to concede. It's 6 months. I'm willing to
6
concede
months.
defeat, but I think you have to have that. It's up to the patient to make that decision.
Same question expanded to return to duty. You have a lot of outdoor aficionados in Utah.
Yeah, I would not let him go back and ski in the backcountry and
Yeah.
fire. I mean, I have a bunch of fire jumpers too, and no way.
So we had extensive discussions. He had to come back several times. We actually did a revision surgery, repositioned the hardware. All the hardware was actually well placed. It just looked very funky. We did a intradiscal osteotomy with an anterior column reconstruction under nerve root preserving technique. So this is a peak cage with local bone graft. We realigned him. And this was, again, a success story. This was done open. And this is postoperative CT scan. So we emphasized the straight thoracolumbar junction. And again, it was really nice because we actually allowed him to full unrestricted duty as a smoke jumper with his 60-pound backpack. So he was very happy. But it was impressive to me. This is as well balanced a young man as you can see. And he literally got up and said, I feel different. I have no idea why this would be. There's clearly a non-union, but without hardware failure. So any explanations on this? Any thoughts? Is it reckless of me to let the young man go back to smoke jumping with his backpack, his survival pack? You said you'd do the hardware removal. Is that an IDF rule, or?
No, I'd say if you're doing a percutaneous non-fusion technique, where you're doing a long construct and you're waiting for the fracture to heal, and then you'd like to take the hardware out to get flexibility and remove all that stuff so you don't get broken rods and everything. But definitely in a young person, if it's possible, why not? Like any other hardware. But I mean, with a thoracolumbar rigid construct to do paratroop, I worry.
We actually got a CT at the 1-year mark. We established full union radiographically, and at that point I felt comfortable. And I thought with a caudal level of L1, I had no problems with him going back to that kind of duty. Any other thoughts from the audience? Just wanted to talk about MIS and some different perspectives. Yes, sir.
Could you just review quickly what happened with the original procedure?
That's a good question. So as I reconstructed at a major institution, they attempted to do a percutaneous fixation. They did not want to do multiple poke holes, so they made one larger skin incision. And thinking that the main pain comes from retraction and dissection of the muscles, they went through the fascia. So that's what was labeled as transfascial. I had questions about that. I had not seen that. But rather than mucking around with multiple tracts, and they actually did a debridement, a small laminotomy over the fracture site. So they, with guidance, actually inserted these screws. I thought for sure there'd be some screws that are in the canal or out of the vertebra, but every screw was actually accurately placed. My personal suspicion is what my colleagues also said, that they had such technical struggles in this thin, muscular man to get this rod threaded through, that the quality of reduction suffered. That's my best reconstruction. Is that a reasonable assessment? So again, I was very surprised that these screws are actually all in there, but they used a guidance system with a reference frame. Is that an adequate answer? No, thank you for asking. All right, so no other thoughts about this. We'll fast forward. Final topic from myself for this part is geriatric odontoid fracture. This was the patient I showed in the morning. Welcome. 95-year-old. This is a real-life patient. She lives by herself. She crashed her car at 60 miles per hour. Neurologically normal, no traumatic head injury. She was very much in pain, and she wanted something done. She also has an atlas split fracture in the front, by itself not devastating. We felt that the TAL was intact. I have an MRI, but I didn't show it here. So shall we switch to a question? So for everybody to answer, is surgery the appropriate treatment in this kind of a patient? Or would you think about a halo or a collar and accept a possible non-union? 95-year-old patient. After all you've heard, and we'll obviously then go for a second question in a moment. Collar non-union. So those who said this is basically okay to do that, 2/3 voted for that. Nobody wanted a halo anymore, so we've won that battle. If we switch back, wait, next question is another question, I think. So if you had to do surgery, for the third that had surgery, and if the family coerced the other 2/3 and said just a collar and nothing, what would be the most appropriate surgery for this after all the things you've heard today? 1 through 4 options. And I'll ask our faculty to think about what to make of the first audience response to accept a collar in a nonagenarian who's totally functional. So clear win. That was you with the Odontoid screw, right, Rick? No, just kidding. 93% for, so we have consensus. That's kind of cool. So what do we make of the response of the audience that collar and a non-union is acceptable in a patient who, until just the day of the accident, was completely independent? Is it our right as a surgeon to basically say, you will not participate in regular life anymore, you can put up with some neck pain now, aside from taking the driver's license away?
So I don't agree with that. I think if that patient was in a nursing home and has very low demands, then that is a reasonable option. But for someone who lives on their own, who drives a car, or in many instances, these are actually caretakers for their spouse. Number 3 is not a good option, to relegate them to a non-union and then all the potential issues of a non-union.
So we'll stop with Dan because he gave the lecture, but Andrew, you're again a national and society eminence on odontoid fractures. What do you think of this audience prerogative to say, when you're nonagenarian, you're SOL?
Well, I kind of tend to believe with that, or agree with that. I think there's some tricks you can use. First of all, when you immediately immobilize someone, their pain may subside after a week or two. The other thing is you can try tricks like nasal calcitonin and so forth, which will actually go ahead and promote union and also reduce pain. And so that's another trick you could use. Because, I mean, taking a 95-year-old to the operating room is not without risk. And I think I would try a lot to talk her out of surgery and see
She
how
drove
did.
her own car. She lives by herself.
I think let's give her 2 weeks, let's give her 4 weeks and see how she does, because I think we're committing her to a posterior segmental fixation. Everybody is, whether you do that at day 1 or whether you do it at day 28, I don't think makes that much difference.
Josh, you come from a different society. You've trained in the U.S. also. Are we crazy in the U.S. to spend somewhere between 3/4 or more of our actual healthcare dollars on the final 5 years of life of our humankind?
Probably.
What would you do in Israel? So that's a logical next
we
question.
would definitely put a collar. And at night, I took a 94-year-old guy who was hiking and he snapped his neck and he fell and banged his. He had an ankylosing spine and he just snapped into 2. And then I took him to the operating room just to stabilize him. But I think for a dense fracture with 50% mortality in 2 years and after a couple of weeks, most of them do much better. I think, at least in my book, I try at least a collar for several weeks and then discuss other options.
So you're the authority. You gave the lecture.
No. I just want to say, I think the number is irrelevant, right? I mean, we had a 95-year-old woman who was living on her own, next door to her daughters, tending her garden, fell down, broke her spine, right? She came in, and for all intents and purposes, she's driving her car, right? You'd say, great, right? Except she has critical aortic stenosis, right? I mean, her underlying medical condition, although she's getting along, was incredibly tenuous. So it's not the number, and it's not necessarily, although their performance status plays a large role into it, it's a complete evaluation of their physiology before you go
Right.
forward. And once you get that, then you can make a decision.
What was your choice here, Dan, if I can put you on the spot? Were you a collar person for this 95-year-old?
No, I would all things being equal, if she could undergo the operation, I'd fix it.
Were you surprised that nobody voted for craniocervical fusion? I've seen this done a lot, and I see a lot of outside referrals coming in where patients had craniocervical fusions for odontoid fractures. Is this something that just shows that the surgeons don't know what they're doing? Is this an anachronism?
I think it's because they don't know or are uncomfortable placing C1 lateral mass screws.
I tend to agree. So let's see what we did here. So this was the patient, and we actually, after lengthy discussions, did a segmental fixation. And we have a CT to show that everything was perfectly placed. I was kind of curious. She came in with kind of a torticollis leaning position. This was a year later. And this is a quote from my medical assistant. It's actually in the chart. She is the happiest patient of the day. She's not driving anymore, but she's still living independently. She was in a skilled nursing facility for about 2 months. True story. But again, I personally think that neurocognitive skills are more important than the numeric age. I think I agree with you. Any questions, comments? You have a international panel of experts. Any disagreements? Ryan?
Does it play a role versus fixation versus collar if they are active, the risk of potentially falling again and having a secondary injury?
Falling risk.
Would that push you more towards fixation?
So again, if I may paraphrase your question, if they have a collar and an established non-union, are there cases of secondary neurologic deterioration? Can we expect a non-union to become symptomatic neurologically?
So I'm going to change that question just a little bit. So we know halos cause all sorts of functional problems. I mean, you put a halo in a 95-year-old frail woman, she can't get up. I mean, the superstructure is huge. She can't get through the door. She's going to lie around in bed, get respiratory problems. You put these people in rigid collars, though, they can't see in front of them. They can't see very well, and their incidence of tripping and falling in a cervical collar is much, much higher than if you operate on them, keep them out of a collar, and let them get away. I'm concerned with even just rigid collars in older patients.
Any other thoughts?
Who are active, active. If they're lying in bed, it doesn't matter. But if they're active and moving around, that's a problem.
It pushes you towards fixation then?
Yes.
Point of information, though, why did you extend the construct? Because of your poor bone quality, or?
Yes. I wanted to, great question. I'm amazed how stable the screw purchase in C1 is, even in very osteopenic patients. I think that she had extremely medial and cranialized vertebral artery formation. I think one segment was very kind of arthritic anyway, so I decided to go a little bit more subaxial. If I'm very critical, I see a mild kyphosis below my construct there. She was doing so well and getting around so well, despite kind of standing a little catawampus, that I decided to not repeat CT her. But I felt I needed a little bit more caudal fixation. Great pickup. Thank you for asking. Chris.
Because you said she had osteopenic bone, so did you, after you fused her, leave her in a collar for a period of time?
We actually took her straight out. We gave her a soft neck collar for comfort to minimize opioid use. And literally, I think a week or two after the comfort phase was accommodated, got her increasingly out of it. I'm going to ask you, since you just came up to the front and present a case of an odontoidium. So this is just a quick topic changer, associate, not associate. There's a condition that we can sometimes see coincidentally. It's a 48-year-old male with neck pain after fall, normal neurologic exam. And so just to preface your thing, let's answer these questions. If you have this kind of a condition, an active patient without neurologic injury, but has some neck pain after some fall, should this be fused? So this is kind of the question about what do we do with C1, C2 if we see a discontiguous atlantoaxial segment. So it should be fused. Assume yes is number one and no is number two. Yes is number one, no is number two. In 1 second, and the answer is, drum roll, most say no. Great. Can we go back to the slides? I'm going to show you just a slight variant to add as an introduction to Dr. Elia's case. So two-thirds said no. Now, this is a patient, sorry, this is the same thing. If you have an unstable odontoidium, would you formally restrict activities on this patient? So would you tell this patient, now I know that there's something wrong, you can't ever play football again? Yes or no? So this patient has an odontoidium, there's some movement there. Yes, so the vast majority said they can't go on with an active lifestyle. So now move forward. So these are helpful things. So most people say you don't have to do surgery. And secondly, they can't go on living like this. And now this whole thing would change, I assume, if we have a neurologically unstable condition like this. So if we ask this is a problem. We still don't have good identifiers on spinal cord injury risk, neurologic deterioration, and progressive instability. Chris, come up here, if you will, and show us your case. So this is the case from last night, Lee. Do you have those up still? This is Dr. Elia. He's one of our fellows. He's an enfolded resident from Riverside, California. And he's on call.
I'm on call. Okay. So the case I'm presenting is a 73-year-old female, very active female, hikes, does yoga, etc. About a year ago, was having some severe neck pain with neck stiffness and decreased range of motion after she was stretching during yoga. Lives active lifestyle. She has not sought out any medical attention for this, but presents to clinic with just neck pain, essentially. Past medication, anxiety, GERD, essentially lives alone. Neurological exam is essentially unremarkable except for a little bit of hyperreflexia in her brachioradialis and patella. And these are her images. You see a flexion extension, lateral view x-ray, as well as a sagittal view
Just
CT
quickly, the
scan.
obvious question, Andrew, you've discussed this once, I remember, I think, a joint sections meeting. Is this an odontoid fracture, it's a non-union, or is this a dysplastic event?
I think to me, given her age and her history, I think it's a non-union of an odontoid fracture as opposed to a dysplastic event. I mean, obviously, if it was a 30-year-old, I think differently, but I think it's symptomatic non-union of an odontoid fracture.
Okay. All right. What do you want to know next? Do you want to ask a question or more data? What's treatment next? Don't give it away.
I think-
Give it away, don't give it away.
I don't remember what the next slide
You
is.
don't remember. Okay, so we have to do let's ask our panel. So just a little neck pain, Dr. Gelb. This is like an odontoid fracture. Dr. Daly thought this is like an old odontoid non-union. This is a very active person capable of doing yoga and doing headstands and whatever, the roll barrels. So is this an odontoid non-union? Is it an os odontoideum? Is this an ossiculum terminale? How do you conjecturize this, and what does that mean for treatment?
I agree with Andrew that I think this is a non-union of an odontoid fracture that was somehow missed at some point in the last several years. It has instability and pain. She's neurologically intact, you're telling me.
Pretty much mild hyperreflexia. I didn't see long track signs tested.
Okay. Yeah. I mean, I think this is, I would recommend to her that the best option for her long term is, especially if she has any hyperreflexia, because so she has any evidence of early myelopathy, that having this fixed is her best bet. But if it was just pain and the pain was only mild, then she said, I can live with the pain I got, I would be more than happy to let her live with it, and then just see her back every 6 months to examine her and make sure that there was no progression of her neurology.
I'm going to ask Mackenzie to make a slide, a question slide that says fix, with number 1 being yes, number 2 being no. Josh, you were kind of an advocate to collar and let go, 76, yoga.
I think surgery.
Surgery. What would you do?
A posterior C1, C2 fusion.
Transarticular fusion into the facet joint, or onlay fusion?
I do arms and, just standard C1, C2 and make sure they're fused. The flexion extension are quite impressive.
Let's vote. Rick, what do you think the audience will say? You have 6 seconds.
The audience will say yes.
Okay.
Being a resident, being surgeons in the crowd, right? Family doctors would be different.
Okay. So,
Night.
okay, let's switch back to the slides and have Dr. Elliott proceed.
Have a group of family doctors.
Thank you, Mackenzie, for doing that so fast. You're, as always, awesome.
Okay.
So quickly go through that.
So a few things about osodontoideum, radiographic features. You'd see well corticated margins as opposed to non-union. You'd also see hyperplasia of the anterior arch of the atlas, and usually a hypoplastic dens plus or minus, as well as a hypoplastic posterior arch of the atlas when compared to the anterior arch of the atlas. And there's 2 types, orthotopic and dystopic. The orthotopic, you'd have the oscal in the location of the normal dens. It moves with the atlas, usually intact cruciate ligament. Dystopic, you'd have the os located near the clivus, and the C1 ventral arch is hypertrophied and posterior arch is hypoplastic, and that moves in unison with the clivus. And here's a little table also kind of delineating between the two. On the left, you'd see an osodontoideum. On the right, you see a fractured odontoid non-union.
Did you read anything about why we think osodontoidea happen? What's the cause? What are the theories that you read about?
Some that are it's congenital, or could be like a previous trauma from like prior to the fusion of the.
Do you know where the synchondrosis is between the odontoid process and the vertebral body of the axis? Where's the synchondrosis? Where's the growth plate?
Isn't it like right where you have the base of the, like a little bit above where the base of the dens is?
Dr. Sasso, help him.
Yeah, well, I think it's clear now that os odontoideums are a early odontoid fracture, that because that they are then developing, still developing, and the vascular supply is developing, they turn into this interesting looking phenomena where the anterior arch of C1 and the odontoid process becomes dysmorphic. But I think it's clearly an early odontoid fracture.
Since you have the microphone, can I have some help from you? Because we had an internal debate, and I called this an os odontoideum, and I disagreed with this being a type 2 odontoid non-union. Obviously, with the caveat, this was an embryologic thing. Can you go back to the slide of the patient? Am I off with that? I thought it was an os odontoideum.
I don't think this is an os. Number one, the anterior arch of C1 is perfectly normal. The odontoid process itself, other than where the fracture is or where it's not healed, is normal. And I agree with Andrew, whoever said it, that this looks like an old odontoid fracture. That's a non-union.
And treatment, since this patient's symptomatic now and knows of this abnormality?
Yeah,
Fusion?
I'd fix it. I'm really concerned about the early myelopathy. If that's really hyperreflexia that's occurring, she may be developing an early myelopathy, and you don't want it to progress.
All right, 89.
Look at the flex-x. It's very impressive for the people. Look at the flexion. Look how far, how forward the posterior arch of C1 is on the flexion compared to the C2. Look at the, right, the space of the, it's really, that's the best indicator. Looking at the C1 versus the C2, it's the clearest one.
Let's see what was done. So I got overruled. This is a type 2 odontoid, non-union. Could have been, though. Okay, keep going. So how did the patient do? What was the decision-making? How was the fusion done? What did you read up on?
So we did a C1 to C3 posterior instrumented fusion, and we used your palm screw technique for the C1 screws. Patient did really well. She was actually discharged from the hospital, I think, on postoperative day 2.
Preempting the question, why C3 and how was the fusion done?
Oh, so the fusion was, so we went down to C3 to get added fixation given her bone quality. We distracted a little bit on the C1, C2 facet joint to put some bone graft in there and decorticate that C1, C2 facet and put some bone graft in there to assist with the fusion as well.
Can you show up with your highlighter? Can you show the bone graft? You can actually see the bone graft in there. Go posterior. Yeah. So this is bone graft in there. And how did she do eventually? Do you have final films?
No, these were the only films I was able to pull up.
Okay, but she did well according to your records.
Yeah, she did really well. She was discharged on postoperative day 2.
Okay. Rick, this would be a translaminar screw in your hands as a primary go-to?
Yep.
Biomechanics, so there were some conflicting studies. So I think Josh asked that earlier. In my review of the Hegenes article, he said it's less stable in rotation than a pedicle screw, lateral mass screw construct. Is that right, or does it matter?
So actually, we did 2 biomechanical studies looking at all this, and looking at laminar screw, pedicle screw, pars screw. The worst of all, pars screw, throw that away, don't even use it. The numbers for, and it depends, again, whether it's flexion, extension, rotation, or shear, that overall the pedicle screw was a little bit stronger than the laminar screw, but not statistically. Not statistically stronger than the laminar screw.
And did you test, I know you can't simulate a fusion in a cadaver environment, did you test load to failure or fatigue loading?
We did not go to failure. We did flexion extension and we did rotation.
And yield point, you looked for a yield point.
Yeah.
We found something slightly different because we did a biomechanical study, Daryl and I, looking at when you took it to the occiput. And the bottom line was if you had 2 points of sort of midline fixation, the occiput and the translaminar screws, it was much less stable in axial rotation than was a occipital plate and pedicle screws.
Yeah, it's totally different. So you're talking about an occipital cervical construct rather than C1, C2.
Construct. Yeah.
Any more slides on this, Chris?
No.
Otherwise, advance forwards. We can go back to my slide deck, please. Great job. Thank you, Chris. So now we want to go away from the odontoid and upper C-spine and hit up something else. So putting it all together, so a really complex patient now. We talked about multi-morbid patients, spinal cord injury, timing, and surgical invasiveness. And so let's bring up Dr. Schell and have us show this patient and then just the clinical outline and then ask these questions. Is that okay with you, Ben? Sure. Dr. Ben Schell is from UT Southwestern, Parkland, and Associated Hospitals. Here's the clicker. So big button is forward, highlighter's top. Perfect. So go back, Lee, go back to the main slide deck of Dr. Schell, please, from last night. He didn't show this case last night. But we promised a constellation, putting it all together, of very sick people, spinal cord injury, timing of intervention, and magnitude of intervention. And thank you, Lee. You're like a DJ. AV DJ.
There you go.
All right.
So this is a 71-year-old woman presented with chief complaint of lower extremity weakness. She'd been having problems for roughly a year. No direct specific traumatic event. She just noticed over the past few weeks difficulty ambulating, having some sporadic episodes of urinary incontinence. And her biggest medical comorbidities are that she has a BMI of 52, but otherwise relatively healthy. She has this very, very remote history of a prior uninstrumented fusion about 40 years ago, and they did a disc on her as well. But otherwise, seemingly healthy for a BMI 52. This is her exam on presentation. So a little bit weaker on the right than she was on the left, basically an Asia D. But then the main complaint of the gait instability and then kind of difficulty ambulating around her house.
And if I may editorialist, she had not walked anymore for about a week now. She basically stopped walking.
Correct, yeah.
She had a long decline over about 3 months of progressively becoming more and more bedridden at a BMI of 54 or something like that.
Yeah, it was just kind of a long, drawn-out, slow, steady, progressive history. And then which one clicks?
The large gray one.
Oh, gotta go back. So I just need the mouse to start the video.
We need Lee help. Lee, can you hit the play button?
Just hit the play button on the video. So there's sagittal CT on presentation. There you go. Yeah, it'll scroll down to the bottom there. You see she has an ankylosed spine the whole way through. And then once it gets down to L2, you'll see the injury, and then the lumbar is the next slide once this slices through.
Who of our faculty has a microphone? Rick, Dan, do you have a microphone? Or Rick, do you want to? Is this ankylosing spondylitis?
Yes.
Good. No question, right?
No question.
All right. Okay, let's switch to the lumbar spine. Same request, please, Lee, if you can switch to the flash through the videos. Now, something has happened here. And she had no known trauma fall. She had, again, a fusion.
Play that one.
Attempt L2 through L5. There was an in situ fusion with a laminectomy. And this woman has progressively stopped walking, and she's been lifted in and out of bed by her family, so no professional care providers.
So why don't you show us the MRI scan so we can get the definitive?
Yeah,
We'll get
that's
the MRIs in a second.
That's coming next.
So she basically has, if you agree with me there, an L2 kind of a transosseous hyperextension injury. Josh, Dan, you gave the lecture on classification. Would you agree with as a B3?
Yes.
It's a spontaneous B3, so there's, again, no known trauma history. Oh, Andrew has the other microphone. Andrew, what would you say this is?
Yeah, I would agree it's a B3 injury by the smell of it.
MRI, since you have the microphone, Andrew, can you kind of comment on what you see here? And we have videos, so we'll ask Lee to flash through the play button.
It looks like disruption anteriorly through the superior body of L2 into the disc space of L1-2, and sort of a very much a hyperextension type of mechanism.
Anything about the paraspinal muscles?
I mean, it's she has surprisingly less tissue back there in the paraspinous muscle. She hasn't gotten up forever.
This is exactly, she has anasarca,
yeah.
So it's terrible.
This can very much be an infection also. There's no story of trauma.
No sepsis, no infection.
Not going into this case specifically, but if you see this going on in a patient with a very high BMI, no story of trauma, you see soft tissue swelling around the psoas, around the disc space, you gotta think of that also when you're looking at these patients. An abscess at that level, which is something that you gotta rule out.
So Ben, why are you showing us this with those little circles there? What does that mean, and what does it mean to the faculty then?
So these are, we call them ROI circles, and so that's measuring the Hounsfield units right here, this mean average right here. Try to do about a centimeter in diameter. So here's our injury at L2, so 1, 12, 11, 10, 9, 8. I was just looking at some potential fixation levels where we may want to stop or start our constructs, and her thoracal, her T-spine is obviously a little bit stronger than her L-spine. Stopping at 5 or 4 would be horrendous. The sacrum gets a little better, but that was just kind of my defense for, well, we'll show you what we did, but I guess we can get your opinions on what you guys would want to do.
So Andrew, I'll start with you, and then I'll ask Josh something else once we get back to the questions. Andrew, do you guys use these Hounsfield units as a screening tool now?
We don't use it as a screening tool. In other words, I wouldn't rule somebody out, but we will use it to try to figure out how many points of fixation we'd use. So, I mean, somebody like this, we do multiple points of fixation. I mean,
So that's a given, right? Even though the HU units on the top don't look so bad, but then
the ones
below.
down below look horrible. So I'd go to Aurelium.
Okay. All right. So let's switch to the questions now. Is that all right with you, Ben? Or is there anything else you want to share?
The next is the post-op slides, and then
So
my
we don't want to do that.
classification
Good.
thing.
So perfect time to switch to the slides. So this patient, correct, that's not a conus majoris, it's probably a cauda equina, because she did have incontinence, so she was placed in the Foley. She had, as I remember, a poor rectal tone and was severely constipated when she came in. So we call this an incomplete cauda equina. Sorry for that, not conus majoris, that's my bad. Now, audience question and faculty question. Would you push for aggressive surgical decompression stabilization? This patient is in agony. She has severe pain. She is bedridden, and she's progressively basically become moribund. She herself wants surgery. Her family wants surgery. Everybody wants something done. So please answer yes or no. Any form of surgery.
What do you mean? I mean, I don't understand the term aggressive.
Just keep going with surgery, or tell her, sorry, you've kind of let this go too much. So preponderance of doctors says yes. Josh, you had the microphone in your hands, and you have a robot, 2 robots, in fact, in Israel with a less maybe aggressive surgical purveyance. What are your thoughts?
I would perk her. I mean,
You would operate.
I think that if I could align her properly, I would go for a short fixation of fenestrated screws, and sometimes I mean, probably have 15 patients with ankylosing spondylitis that thoracolumbar fractures, not BMI of 52, thank God, but they heal very quickly. So once you get them stable in short, 4 screws, 8 screws, doesn't matter, but you FNS them and they heal very quickly.
Why did this happen? Why did her fracture happen?
Long lever arms, bad bone, points
Ricky,
of
you
fixation.
were going to say something?
Yes. I'm curious about your description of an incomplete, I think you said there's incomplete cauda equina injury. I've never heard of that.
So I think we need to have that term, because she basically was incontinent of bowel and bladder. She had paresthesias in her cauda equina region. She had a anti-gravity plus motor exam, but she is basically not able to walk anymore. And her weakness basically is from her thighs down. She also has severe pain. So
she has cauda equina syndrome.
Well, that's a good arguable point. I mean, if you call it black and white, I would give her cauda equina, yes. If you put me to the point like that.
Okay.
But it's not a complete, meaning there's no Asia A from a motor level. But I'm happy to take your suggestion to just be clear about it. If I was put on the stand, I would have to say this is a cauda equina, yes.
Yeah, but what I think is interesting is I think there is an evolution of cauda equina, right?
I agree.
mean, it's not just black and white sometimes. Sometimes it's difficult. It's hard.
Keep your microphone on. Question number 2, please, Lee. So how do we do this now? Do we do a formal, open, comprehensive surgery? So do we stabilize it like what Dr. Daly said, multi-levels, and decompress this mess, which starts somewhere around T12 and goes actually all the way down to L5? She has a non-union of her L5 as one segment. Or do we do a percutaneous fixation, maybe a small decompression, and follow Dr. Schroeder's recommendation? So let's vote. And as the voting comes in, we have 9 seconds without influencing anybody. Dr. Sasso, what do you think people will vote for?
Number 1.
Okay.
Number 1. Everyone.
Dr. Schroeder, what do you think? Whoa, here we go. Whoa, big time open. Dr. Schroeder, what happened?
I think that these cases are great for percutaneous cases if you know how to do them. I think if you're doing it open on a 50 and a BMI of 50, you're going to get into a lot of trouble afterwards with wound healing and all that stuff. And I think that you could easily place percutaneous screws with the technology, which otherwise is very, very
So
challenging.
now let's go to the left / right wing.
Well, I think that your ability to, in this kind of patient, your ability to do percutaneous fixation without a robot is completely dependent on your ability to visualize the pedicles with fluoroscopy. So in very severe osteoporosis and very severe ankylosing spondylitis, it's often difficult to, in big people, it's difficult to visualize pedicles. So it may not be technically feasible to do MIS. However, we've had more than one patient with this kind of problem dislocate their spine spontaneously when they're positioned on the table, no matter what kind of frame you use, because they're so unstable. When she's this big, she's got big belly, you put her prone and she pulls herself into extension and she gets worse. One of the nice things about MIS is you can do the patient sideline. You can fix the patient with them laying on their side in a nice curled up position. Right? So you can work across the table. You don't have to worry about her dislocating, and you can get her stabilized in that position.
I'd say even more, if you're putting her on one of those big humps to get her down, the abdominal pressure is going to cause a tremendous amount of bleeding because of the venous pressure in the abdomen. If you can get away with a great positioning, any technique, beanbag, whatever you want to put her on, and then you can perk her somehow,
So, Josh, this perking term, I'm very suspicious of that. Have you done these laterally? Is your robot capable of doing this laterally?
The robot is capable of doing laterally. I have not done it yet.
Better than a human, right?
What? In human?
Better than a human. Better than a human, right?
No, I don't think. I think that if it sees things better than we do, I think you can do that also for other forms of navigation. I think that in severe osteoporotic patients, that's what it's for. It's not for a L2 to L4 and an 18-year-old boy. That's
The far right, far left speaker.
So can you just go through, just because we just got a robot, so I'm trying to figure out how to use it. What you do for data acquisition, do you plan it on an AP and lateral fluoro? Do you do an intraoperative CT? Do you do the preoperative CT? How are you planning for this? Because, if I did just an AP and lateral fluoro, I still couldn't see what the hell's going on in there.
You don't need to see. One of the great things, no. Look, you can do either or. You can do an O-arm spin, you can do a pre-op CT and fluoro acquisition, you can use a Zigo machine. All of them work with the robot. One of the nice things about these technology that they actually see, it's a computer software, so you don't need to identify the stuff. It knows how to build the algorithm. You need to make sure you don't have any platform shifts or any motions during you're doing the segment. There's a lot of pitfalls in how to do it properly because things move around, and it assumes, definitely in a percutaneous fixation, it assumes that nothing's moving, so you really got to get your patient stable. Huge BMIs are an issue. Sometimes you do two above and below kind of fixations. But in really tough cases, it's an enabler. It's not just a technical trick because of the power of computer.
Josh, there's a euphemism I really don't like. It's called learning curve. How long is the learning curve for something like this?
How
many patients?
For a BMI of 50 in an osteoporotic patient with a deformed spine, these are the toughest ones. But it's a confidence builder more than anything else, and I think I would say at least 50 cases before you can do it properly.
Josh, since you have the microphone, how do you interpret the result of the audience? You're a very convincing speaker. You've done 1,000 cases with a robot and navigation, with a brand new, unbelievable high-tech Israeli technology. Yet most people sided with doing it the conventional way. Do we just not know?
It's like going up to the occiput. You need to trust the technology. I think, and I must say that there are 4 or 5 systems out there. I think that it's a big hype. I think that some of these robots will be in the trash can in a year or two. They're just not feasible. And I think that, it's a generation 1 cell phone, right?
Great. Okay. Let's switch. Thank you, Lee. Let's switch back to the slides. Dr. Schell, take us to conclusion. Andrew, what do you think will happen? So, what do you think we did?
I'm going to do a long segment.
Okay. All right, Ben, what happened?
So we can scroll through these videos as well. So we did a T9 to pelvis open instrument fusion. We did it on the Wilson to try to get some kind of reduction intra-op. If Lee, you can click it whenever you get a sec. Let that roll through the video. Lost about a liter of blood loss.
How long was the surgery?
Surgery was close to 8 hours. It was a long time. We got a great closure. She actually had surprisingly good fascia, that we could kind of separate out on the way in despite having the revision surgery in her lumbar spine. So we still got...
Lee, can
you click the video?
Arrow? Thank you.
But it was very, very difficult. We also did TLIF at 5S1 with bilateral rise cages to try to get some anterior column support. But it was very, very difficult in the previously uninstrumented fusion area to find and identify pedicles. Screw placement was very, very tough.
And what did we find when we laminectomized her?
She had a large hematoma that had been there for a long time.
And dural erosion from a fracture.
Yes, yeah, and the dural was basically atrophied right at the fracture site, L2. We did a T12 to S1 laminectomy. We opened it all the way.
How did she do so far?
So far, so good. Her pain's improving. Her neuro exam is about the same from pain. She's got the neuro exam the next page. I'm sorry?
How long is she out?
How long was she at the hospital?
No, when was surgery done?
So surgery was just the week before Thanksgiving.
Yeah, 3 weeks now.
Yeah.
She actually mobilized very nicely. She was a little bit pain-free. Do we have to do an anterior column support now?
I don't think it's going to help you.
Okay. Any?
No, I have a comment and one question, though.
Fire.
The comment is, everyone should know ankylosing spondylitis, incredibly high incidence of epidural hematomas. Extremely high, extremely high. My question, though, is, did you attempt to get a correction of her kyphosis? And tell us about that. Either whether you try to get it or you try to put it back to where it was, or whether you're going to help her with a correction of her original kyphotic deformity. And how do you know where she was to begin with anyway?
We don't know where she was to begin with, but we tried to get her back on the Wilson. We got pre-prep films, pre-prep fluoro to try to reduce her on the Wilson as much as we could, and that was as good as we could get it.
Also, we tried to under-contour the rods, but there was only so much give. So we did not go to great extremes. So this is the construct we used. We have a plastic surgeon who helps us.
4 rods. Tell us about the 4-rod construct.
Dr. Schell wants to talk to you. How did you know that? Dr. Schell wants you to know about 4-rod constructs.
So this is a multi-rod construct, kind of colloquially known as what we call a quad rod here. Taking off, being more prevalent in the literature in the spine community. We use them quite often here for various reasons. And so that kind of leads me to the next part of my presentation. So here at Swedish, we do kind of year-long research projects. And one of mine is to try to develop a more consistent nomenclature for these multi-rod constructs. So Dr. Chapman teaches us something called an elevator pitch. So my elevator pitch here is that there's no consistent nomenclature, kind of like your discussion earlier about the classifications of thoracolumbar spine trauma. So there's no way for me to talk to my colleagues about quad rods. There's no way for me to discuss this with somebody on the phone. There's no way for me to convey to my attendings on the phone when I'm on call about what's going on with these patients. And so you end up with things like this. So this was actually done in an outside hospital that came through here. And so I think we need to develop a multi-rod classification system with more universal nomenclature, more universal words, more universal way to describe it and talk about it. We still aren't sure what they were thinking here. There's a break in the rod here. This rod, I'm not entirely sure is even attached to anything, but it was done at an outside hospital, so it ended up on our front doorstep. That's not the point here. The point here is that throughout the year, I've kind of, through talking to all the attendings here and kind of working through some of the research papers, there's a whole list of words that people use to describe these. And so this is kind of the classification system that I've developed with the help of my co-fellows and my attendings here. So basically it asks 4 main questions about each rod construct. So the first question is, how many rods are there? That's usually relatively easy to see from an AP x-ray, and we'll go through a couple cases here in a second. Then the next question is, how far rostral does that construct extend? I divided the spine up into 4 segments: cervicothoracic, mid-thoracic, thoracolumbar junction, which I think is very important due to the motion, and then how far does it go down to the pelvis? And then the third question for the functional rod, the shorter rod usually in the construct, the functional rod, we developed this abbreviation for why was it placed. That way, either from the previous op notes or as these classifications are getting propagated through research, we know why these constructs were done rather than just looking at random rods that were placed, quote unquote tinker toys, according to one of my co-fellows, about why were they done. And then to put an emphasis on the poor bone fixation, or how long the construct is, or how much it really needed. How many screws went into the ilium, went into the pelvis.
So let's flash through this rapidly. So
This is my current working name for it. It's the Chrome classification of heterogeneous rods for multiple etiologies. It's a work in progress. So then I've got a couple case examples that I kind of wanted to run through. It's a little modified Delphi process here. We have a lot of experts, a lot of international experts, kind of test the classification system as I'm working through it. Sorry to put some more work on you guys. So here we have a couple case examples. They're on your sheets here. There's a little, on your sheet, there is a sample of the classification. So I'll give you as much information as I think is appropriate for the classification. I've purposely withheld some stuff just to see if we can have some variation. So it's a 68-year-old woman. Her construct goes up to T9. It does go down to the pelvis, and it was performed for a pseudoarthrosis at L4S1.
Is this case 1 or this is example 12?
This is case 1. Sorry, that first line is just an example.
Okay. Do
Sorry.
broken rods count as one rod?
So these rods are actually not broken. These rods were placed that way. These rods were placed that way.
Oh, man.
This is why we're testing it. To see what this comes up with.
Wow.
So this is number 2. It's a 74-year-old man. His construct, those hooks are in T2 at the top there. And this was done for deformity correction with pseudoarthrosis at L12. Oh, sorry, not ready? Sorry. Dr. Chapman said speedy.
All right.
Number 3, it's a 58-year-old man. His construct goes up to L2, down to the pelvis, and then he had a pathologic fracture from Charcot that was fixed. We'll say it was fixed.
Can you just tell us, are there 4 rods
two
there?
rods?
2 rods are over.
Yeah, so this is a set of 2 rods here, and then there's 4 rods here total.
The 4 rod. The 2 and 2.
2 kind of superficial and then 2 deep.
The 2 working rods and 2 spanning.
Correct, 2 spanning rods and 2 functional rods.
Whoa. All right.
Number 4, this is actually the lady that we just showed. So her construct went from T9 to the pelvis, and she had that L2 extension fracture. All right, number 5, this construct goes up to T4, down to the pelvis, and then this was for a decompensated kyphoscoliosis is why the multi-rods were used.
I think we're good.
Okay. Again, up to T4, down the pelvis for pseudarthrosis with broken rods, but this is obviously post-op. Yeah, these are rod connectors, yeah. But it's 1, 2, 3, 4. There's supposed to be some variation, Eric. Number 7, so the construct goes up to T10. It was done for pseudarthrosis. And again, so this is 1, 2, and then down here, there's 2 spanning, and then 2 functional. 2 and 2. Just a couple more. Constructs up to those hooks themselves. This is a separate rod that was left that cannot be removed from a prior surgery. But
It can always be removed.
well, that's fair. That's fair. And it was done for Charcot.
The upper bit's a fusion mass. They didn't want to dig into it.
There you go. Yeah, you disrupt the fusion mass. Oh, no? I'm so confused. All good? Second to last one. 43-year-old woman, construct goes up to L4. She had a pathologic fracture from breast cancer through the sacrum. And then last one, 74 woman, construct from T10 down to the pelvis, and she had an affected non-union at 5'1". And maybe a little tough to see, but there's 2 spanning and then 2 functional rods on each side. And so obviously I'm more than open to interpretation from any of the people on our panel. Any tips, tricks? There's a lot of space on the paper if you guys want to, contribute to this classification system. If you have any good marketing names, I'm open. I'm more than open to criticism if you think it can be improved.
Thank you for participating in this
Yeah,
live
thank you so
research.
much.
This is the first round of formalizing a Delphi process.
Thank you.
The observation from us that brought this about was we saw a lot of messing around, like that one case that didn't come from here, with crazy rod constructs which did not fulfill a role. And we thought this should not be just done. We see this far more now. We see far more patients coming in with rods that didn't make sense. And so we thought that this should be, and Ben took this on himself, kind of more systematically assessed and categorized. So is there clinical merit in this? And how should we proceed with this? Is this something that any word of guidance for Ben would be appreciated?
I love it. I mean, right now I just call it multiple rods, right? Because we don't know.
That's what we do.
So I think it's great.
Have you seen this kind of nonsense where there are rods that are floating around in the middle of somewhere?
Every day. It's
a growing phenomenon, right? And they don't make sense. Is that same in Utah, same in East Coast?
Oh, absolutely. What you'll see is an old fusion construct, a new fusion construct above it. Quad rods up above, and then just 2 rods down below, and then a non-fused level in between. I mean, it's just unbelievable.
Dan, does it make sense to use the words working rod as the primary biomechanical force rod and then a spanning rod, or are there better words that come to your mind?
No, I think those are great. I haven't come up with a term for it, but yeah, I use quad rod or 4 rod technique most commonly when I do like a PSO, and that's exactly what we do. We do a short rod to close the osteotomy. We bury those screws, and then we have a long rod that kind of flies over those screws.
Yep.
And we do 4 rods that way. I personally have never understood the kind of the satellite rod phenomenon because it's just going to concentrate force at the connectors above and below the area where you're putting your 4 rods. So
Sure.
that we did a project actually with the Globus people in their biomechanics lab, and I think it's been presented as at least as a poster, if not as a podium, but I'm sure it's not published yet, looking at different rod patterns in terms of if you do an osteotomy, how the different rod constructs affect the biomechanics, which I think is really where we should start.
For sure.
We should look at what's the effect of changing the rod patterns, and then go from there.
All right, yeah, Chris, sorry, Alex.
Just one question to the podium as well. Would you think it would make sense to go more into detail regarding the classification in terms of pelvic fixation? Because right now we just say more than 2 pelvic or whatever kind of screws you use to fix the pelvic. Would you say it makes sense to differentiate between S2I screws, iliac screws, maybe even modified iliac screws? So would it make sense, in your opinion, to differ that in such a classification, or would you say I don't care how it's fixed to the pelvis?
Until you could show me that there was a clinical difference in outcome based on the type of the screw you used, I think it's irrelevant, right? I think because you live where you live here, like you guys probably are, oh, we'll put 4 screws in the pelvis, or we'll write. I think nationwide, you'll find a very small percentage of surgeons who will ever use more than 2 screws, 1 on each side of the ilium. I think that's a relatively that's a location bias.
Okay.
Can I just say, I think that some of these multiple strange rod constructs are coming because there's so many different kinds of set screws out there. And you don't always have, I got a patient that was operated down in Brazil, and he broke adjacently, and he had a diffuse system inside. I brought him in, and it was a different set of set screws and different set of connectors and all that stuff. And sometimes these patients have 3-4 companies inside of them, and it's almost impossible to start to deal unless you have a universal removal set. It's almost impossible. Then you're finding all these funny connectors trying to put the stuff together to end up. I'm just trying to justify trying to explain maybe some of these strange constructs.
Well, this will close our Picha Kucha session. Thank you for our wonderful faculty. And we'll go for the final slide deck, and we have a couple of questions here. Ben, congratulations. I think you're on to a good start. All 4 faculty liked it. So, question for all of you. Do you like ARS as an adjunct for lectures? We really want to know, this is anonymous. Please hit your response.
Having a what? ARS?
We had it a lot with AO, and I don't know if there's some cell phone-based things, but they've not really come through. So if you like it, let us know. Wow. Whoa. Did you notice that? I did not predict that. That's cool. That's nice. Congratulations, Mackenzie. Did we meet your educational goals? We said 2 things in the beginning that really highlighted your interest. Focus on spine injuries of the elderly and managing complications. We tried to switch things on the fly a little bit. So just an honest yes or no. Wow, very good. Thank you. Then next question. Is it helpful to have a spine trauma symposium? Again, my bias is very clear. I think that there's not enough emphasis on spine trauma in our professional societies, but that's just my bias. So honest answer, is this a helpful thing? Eric, I'm watching you. Are you doing that was your second press. Okay, wow. Thank you. Okay, do we have another question? Did you find the surgical demonstrations helpful? Again, having experts in the field was something we discovered about 2 years ago, resonated very well, but we again want to know whether you find this helpful or not, just in general. Refinements and comments are always well taken. Wow, another 100%er. You guys are great. So thank you to our faculty again. Do we have final slides for me? Can you switch back to my final slide? So thank you. And we'll get changed for the labs in a second. So I'm just going to flash through this. So again, I want to think of Gary, but a couple of acknowledgements. So surgical labs, we really appreciate your feedback on that, also technical tips and tricks. We continuously try to refine this. I really want to thank these companies, and please go into the lab. You have 4 lab stations. Globus, DePuy Synthes, and Nuvasive are the main sponsors for the surgical labs. You have 4 world-class specialists here, and I will be rotating through there also. I want to also thank our exhibitors, Integra, Medtronic, Precision, and C-Spine. Without their support, this kind of an event would not be possible. And I want to really thank our outstanding speakers and their passion for educating on a Saturday away from their families and their work. This is a big commitment on their part, and this is really an outstanding group. I feel very privileged to have had this interaction with all of these friends and colleagues. So please, another round of applause. And of course, our SSF team with Lee right here, with Megan right outside, with Tyler in the lab, and with Megan at the front desk. So thank you. We want to conclude with a pretty hard stop at 5:45. So we have about an hour to rotate around the tables. And whatever you want to do, these are the world experts. Let's make good use of the cadavers. Thank you.